Welcome to the program on cleft lip and palate. We have planned a series of webinars for this month on cleft lip and craniofacial syndromes and deformities. And the first of the series is on primary care for the cleft lip and palate. And we have Dr. Krishnamurthy Bananteya, is known to every one of us, and he is a well-known face in the field of oral maxillofacial surgery, not only in India, in worldwide. And to introduce himself, it's a real pleasure. And he's an oral maxillofacial surgeon who brings with him more than 3 decades of varied experience in this field. And Krishnamurthy sir graduated in dentistry from the Government Dental College, Bangalore, and in medicine from the Kasturba Medical College, Manipal. He was trained in maxillofacial surgery at Manipal initially, and later on in the United Kingdom, and as a postgraduate qualification in oral maxillofacial surgery from Mangalore University, as well as in the Royal College of Surgeons of London and Ireland as well. He has worked in various clinical and academic positions in some of the well-known institutions in Karnataka as a consultant as well as a professor in oral maxillofacial surgery. He has specialized in the discipline of cleft lip, palate, and craniofacial anomalies and runs a cleft palate center at the Bhagwan Mahavir Jain Hospital, Bangalore. He has been an editor in the journal Maxillofacial and Oral Surgery, which is an official publication of our association, AOMSI. And he has also been an editor of the Journal of Cleft Lip, Palate, and Craniofacial Anomalies, which is an official publication of the ISCL PCA. And currently, he is the Vice President of the International Board of Certification of Specialists in Oral Maxillofacial Surgery, the IBISCOMS, and currently the President of the Indian Society for Cleft Lip and Palate. He has also been the immediate past President of the AMSI. It is a pleasure to have you amongst us, sir. Welcome to the program.
Thank you. Thanks, Jim.
Thank you. Thank you, sir. Now it's my pleasure to introduce the panelists. Dr. Abhilasha Yadav, who has completed her MDS from Nagpur University, and she is also the first maxillofacial surgeon to be awarded with a PhD in Maharashtra. She is the professor and head in the Department of Oral Maxillofacial Surgery, Abbas Dental College and Hospital. She is a credentialed smile-trained surgeon since 2011. She has numerous presentations in the national and international conferences and numerous publications in the national and international journals. And she's also serving as reviewer for many reputed journals. She has contributed in 7 chapters in the textbook of oral maxillofacial surgery. And her surgical areas of interest are cleft lip and palate and congenital deformity correction, facial aesthetic and reconstructive surgery. And she has also been awarded with the prestigious Jinwala Trophy for the best scientific paper at the 42nd Annual Congress of AMSI at Nagpur. Welcome, Dr. Abhilasha, to the program.
Thank you, sir. Thank you so much for the opportunity, sir.
Next on our panel is Dr. Varun Menon. He has been a cleft and craniofacial reconstructive surgeon in the Smile Train Accredited Center, Department of Charles Pinto Center for Cleft Lip and Palate and Craniofacial Anomalies, Jubilee Mission Hospital, Medical College and Research Institute, Thrissur. He is also an international board certified fellow of International Board for the Certification of Specialists in Oral Maxillofacial Surgery. He is a fellow elect of the Academy of Dentistry International, fellow of the Pierre Fauchard Academy, AVO fellow craniomaxillofacial trauma and reconstructive surgery. And he is also an associate fellow of American Academy of Implant Dentistry. He has authored many scientific paper presentations and journal publications in national and international journals, and his special area of interest, cleft lip, palate, and reconstructive surgery. Welcome, Dr. Varun.
Thank you, sir. Thank you.
Dr. Pasupati, he completed his oral maxillofacial surgery from the Government Dental College, Chennai. He was an associate professor in oral maxillofacial surgery at Jubilee Mission Medical College and Research Institute, Thrissur, and is also a consultant reconstructive surgeon. And at the Charles Pinto Center for Cleft Lip and Palate and Craniofacial Anomalies. He was there for close to 7-8 years, and then he was a consultant oral maxillofacial surgeon at the Cleft Reconstructive Center at Rajan Dental Institute, Chennai. He has operated on 1,000 plus primary cleft lip and palate reconstructive surgeries, rhinoplasty and other secondary cleft reconstructive surgeries. And he has assisted Dr. H.S. Edenwala, the legendary cleft reconstructive surgeon, as his first assistant from April 2009 until 2016. And right now, he is the consultant in a reconstructing cleft and reconstructive surgeon at Kanchi Kamodi Child Stress Hospital, Chennai. Welcome, Dr. Pasupati.
Thank you, sir. Thank you so much.
Dr. Sneha is the next panelist. She's a consultant head and neck surgeon. She's a fellow of the Cleft and Craniofacial Surgery MCCC, affiliated to CCI Zurich, and she is trained in regenerative medicine as well. She is a consultant oral maxillofacial surgeon in Kumaran Hospitals in Chennai, Muller Hospital, Muller Orthopedic Hospital in Chennai, and she has worked as a cleft surgeon on Lifeline Express, a central government project in a foundation collaboration with UNICEF and WHO. She has been awarded the best outgoing student in undergraduation from the MS Ramaya Dental College Hospital, Bangalore. She has been awarded the RS Neelakandan Award for securing the university first place in post-graduation in the field of oral maxillofacial surgery, and also the Dr. Nandagopal Award for securing the university first in the basic sciences examination during the post-graduation in the year 2007. Welcome, Dr. Sneha, and she is the currently the reader in oral maxillofacial surgery in the department of in SRM Dental College, Chennai. Welcome, Dr. Sneha.
Thank you, sir.
Now, I would request the moderator, Dr. Krishnamurthy Banantia, sir, to share the screen and take over the presentation, sir. Thank you.
Thank you, Jim. Thanks a lot for this opportunity. I must say, I was hoping to have a very quiet Sunday morning discussing a few aspects of cleft and craniofacial surgery, particularly on unilateral and bilateral cleft lips and palate. However, I must say, can you hear me, Jim?
Yes, sir, we can hear you, sir. We can hear
and the screen is on now?
Yes, sir.
My
yes.
screen? Yeah.
Yes.
I must say I'm pleasantly surprised on a Sunday morning to see more than 150 people coming in for a cleft session. Most of the times in an annual meetings, I'm talking about the national meetings, where I get a chance to speak on some aspects of clefts, there are hardly about 20 to 30 people out of a crowd of 1,800 delegates. So that's a pleasant surprise, and this I hope inspires all of us to perform to our best. Basically, the Tamil Nadu State AOMSI has kindly asked us to do these discussions on primary care in cleft lip and palate, and we have a significant amount of time, so we will go through some of the aspects. Obviously, cleft surgeries, management of cleft deformities is quite complex. It's something that interdisciplinary teams struggle to agree upon on all aspects, and today this is just a group of 5 surgeons who are going to discuss various aspects of cleft care. So you will find that, and as well as the audience, most of them I would believe are either qualified maxillofacial surgeons or trainees. So I think we are going to lean heavily on the surgical aspects of cleft lip and palate surgery today. However, other things will creep in, and we will try to discuss them to the best of our abilities. So we will start off with what happens when a baby with a cleft lip and or palate is born. And one of the most important issue, even before we start thinking about making this face look beautiful and make this child smile, is how to get the baby to feed. And we all know that breast milk is the best and the only form of nutrition for a child in the first 4 to 6 months. And the WHO over the last few decades has successfully sold this message and then has reaped the benefits of that, or millions of children have reaped the benefits of that. However, unfortunately, when these children, particularly with cleft palates, are born, breastfeeding becomes a difficult issue, almost impossible in most instances, and therefore feeding these children itself is a significant issue. I must hasten to add here that if you had just a cleft of the lip, it does not hinder breastfeeding, and the mother should be able to carry on normal feeding activities in the absence of a cleft palate. When there is a cleft palate, for the beginners amongst you, the problem is that the child cannot develop a negative pressure inside the oral cavity because of the communication with the nasal cavity, and therefore fails to have an effective sucking mechanism. And though the baby tries hard, she will find it difficult to get adequate quantities of milk, oftentimes spending more energy in getting out some milk than the energy that she gets out of that milk. So this can be a very difficult scenario. So feeding is something that we worry about straight away. There are special feeding techniques for these children. Most important thing you need to remember is that they have to be in a seated position at about 45-degree angle, and then you can express mother's breast milk. Remember, breast milk is the best. So if the baby can't suckle, you can ask the parents, mother, to suckle the breast, express the breast milk and feed the baby. The feeding can happen with a spoon, with a palada, which is nothing but a small snouted cup, a tiny small snouted cup that is popular in many parts of this country. And there are also specialized bottles that are available, which doesn't require the child to suck, but drop into the mouth slowly from a reservoir. But this requires some training, and in some serious cases of difficulty in swallowing with significant retrognathia, where there may be some reflux, etc., you may then have to feed them with an orogastric or a nasogastric tube as well. So one of the things that we as cleft carers might be asked to do is to train the mother to feed the baby. And one common question that comes up often is that this is something certain pediatricians think is being done. There's obstetrician who think is being done, so they send the patient to you saying, can we provide the child with a feeding plate, a plate that can obturate the cleft palate so that the baby will be able to feed. So we will first start off our discussion with feeding plates, and may I ask Abhilasha to tell us what is a plan when somebody is referred to her with the recommendation of giving the child a feeding plate. Abhilasha?
Yes, sir. Thank you, sir. Sir, in cases wherein we have complete cleft of the lip as well as palate, we prefer, if the child reports early, we prefer doing NAM, nasoalveolar molding. So in that case, what happens is when you are providing a nasoalveolar molding plate, it acts as a feeding plate as well. But for isolated patient, unless and until the mother is facing problem feeding the child, we don't prefer giving feeding plates to the cleft palate children. Otherwise, yes, for the cleft lip cases, it comes with the NAM plate, the nasoalveolar molding plate itself. So in those cases, we prefer giving the plate.
So what you're saying is that in these children, you carry out a pre-surgical procedure, orthopedic procedure called nasoalveolar molding. And as part of the nasoalveolar molding appliance, there is a intraoral plate which can act as a feeding plate. So you don't usually provide a separate one. That's what you're saying, right?
Yes, sir. Yes, sir.
Pashupati, right. Do you want to add on to this?
Yeah, the same as Dr. Abhilasha mentioned. Another thing is if a parent is coming to me and asking for a feeding plate, I would first try to dissuade them. I would give them all other options that you mentioned earlier, like palada or special bottled feeds that are available. That are more easier ways to handle feeding, unless and until the child has swallowing issues. So
Right.
that's an easier way if NAM is not considered.
Right. Sneha, are you in agreement with this, or do you have some other
Yes,
thoughts?
sir. Yes, sir. Definitely. But the only consideration is that when the child reports to you is the main issue. If the child
Right.
reports to you as early as within the first 1 month, NAM is always the best choice because it helps you surgically and also in feeding. But often, so in my case, it is not in the first month that I see these children. I see in second month, third month, 3 months. So at that point of time, if we still have problems with weight gain, then I would go in for a feeding plate, which is only if it is a complete lip, alveolus, and palate. If it's an isolated soft palate, I don't recommend a feeding plate at all because he will not have significant deglutition issues, and generally they don't have issues with weight put on and all these things.
Right.
But yes, if at all the child reports early, NAM would still be the first choice.
Right. So there seems to be a consensus here, people, that most of us or all of us would like to do something called as a nasoalveolar molding to these children as part of our pre-surgical preparation. And when we do this nasoalveolar molding, as part of this procedure, there's an appliance that is used, which also acts as a feeding plate. And none of us in this group generally do recommend a separate feeding plate. We have other better techniques. But Sneha made an important point that if a child comes in after 2 or 3 months of age, when nasoalveolar molding cannot be started, and then there is feeding issue, she might consider a plate. So that is an uncommon occurrence. So having taken care of the feeding issue and allowed the baby to grow, let's go to this topic of nasoalveolar molding, because this is something that has already come up a number of times when we discuss feeding. This is what is considered as a pre-surgical orthopedic therapy, pre-surgical nasoalveolar molding. Pre-surgical orthopedics comes in various different forms and shapes and techniques. So we are going to today discuss on nasoalveolar molding because that's where most common contemporary pre-surgical orthopedic treatment is focused on. And before we actually discuss the nasoalveolar molding, I would like you to have a look at this slide where we have highlighted some of the features of the deformities that you see in a unilateral cleft of the lip and nose, particularly on the nose on the right hand side. You will find that there is significant asymmetry, not only in the jawbone. The maxilla is broken into 2 fragments. The one on the non-cleft side we call the greater segment, and then the one that is behind the lesser segment, which is on the cleft side. This skeletal abnormality itself causes a significant degree of asymmetry. The greater segment has moved outwards and laterally, and the lesser segment is far back, so that the base on which the nose and the lip rests itself is skewed. Therefore, whatever you see on the lip and nose, whatever correction you carry out on the lip and nose may turn out to be less than optimal because of this skeletal discrepancy or the alveolar discrepancy. But what you see on this is particularly the nose in a unilateral cleft lip and nose. Most common thing you find is that there is no nasal floor. In other words, the nostril and the oral cavity are in continuation with each other. You find very significant asymmetry. You will find that the columella, which is the portion of the nose that connects the lip to the nose, is much shortened. Look at the black line on the figure. On the non-cleft side, the columella is about 5 millimeters long. On the cleft side, it's only about 2 millimeters long. So there is a hemicolumella length deficiency. Okay. You also find with the red line that the columella is deviated. Normally, it is more or less straight in the midline, as we shall see later. Here, the columella is going right across to the non-cleft side, and so is the nasal septum, which is marked with the dotted purple line. the columella as well as the nasal septum deviate or they're displaced towards the cleft side, that itself produces a significant degree of deformity or asymmetry. And look at the nostrils. You look at the shape of the nostrils, you can look at both the pictures, you find that on the normal side or the non-cleft side, the nostril shape is more or less oval, whereas you find that on the cleft side, the nostril is completely collapsed. It is drawn out laterally, more or less resembling a wavy line rather than a curved oval structure. So this shape of the nostril itself gives a significant asymmetry to the face, which is very glaringly obvious. And also the cartilages that are present within the skin lining here, the lower lateral cartilages again are stretched on the cleft side. They're stretched horizontally, and then they're also pulled down posteriorly there as well as backwards, providing a significant three-dimensional deformity that you're seeing here. If you look at the lip itself, it's not marked on the left-hand side. You will find that the length of the skin, observe this carefully, this is one of the most significant problem that we have as far as the pathology is concerned. The length of the skin at the edge of the cleft. Look at the non-cleft side. The length of the skin at the edge of the cleft is much shorter than the length of the skin on the normal side. So when we bring this together, reconstruct this, one of the important challenges where you seem to flounder often is in making sure that this length of the future philtral column mimics that or becomes equal to that of the non-cleft side. So there are a number of challenges here. Obviously, the skin, the mucosa, and the muscle are not together. You have to bring them together. While you bring them together, you will have to manage all these discrepancies. Therefore, you have a technique called as nasoalveolar molding. Varun, can you start off with when you start nasoalveolar molding and what do you do basically with that?
Yeah, we tend to see the patients quite early because Kerala, as you know, is very well educated. People are concerned. So we see right from birth, people coming in and asking, even prenatally, people come and ask what to be done. So they are very much anxious. So
Prenatally, as in after an ultrasound diagnosis of a cleft lip. Yeah.
So right
okay.
from birth, people bringing the child asking what to do, when can the surgery be done. So even the bystanders and the relatives, they drop in and ask about all these things. So once the taping and all is done, they are quite relieved to see the segments coming together. So here.
So when do you normally start it, Varun? At how many days after the baby is born?
Within 2 months of age.
Okay. Okay. Abhilasha, what is your practice of starting nasoalveolar molding? How early after the baby is born do you start nasoalveolar molding?
Yes, as early as 2-3 days after the birth, sir.
Right. So as soon as the baby is born, as soon as they come in for the first visit, within few days, if they do turn up, you would start nasoalveolar molding. Sneha, do you agree with that?
Yes, so probably around 2 to 3 weeks post-birth. Within a month should be good, sir, because I think the cartilage is more moldable when we start early.
Right. So here is the opinion that nasoalveolar molding, remember this, I've already mentioned that this is pre-surgical. So we do this procedure before we do the cheloplasty or repair of the cleft lip. And it is started as soon as possible, as Sneha pointed out, that we are trying to mold the nasal cartilages here with the help of the appliance that you see here, a nasal bulb. And molding of the nasal cartilages works well the earliest, and later on it is difficult. So the earliest time at which you start NAM is as soon as possible within the first few weeks of life. At our center, we also start off in the first week of life, provided this is something that is important, provided the child or the parents present to us soon after birth. This is something that can be a hindrance. Oftentimes, colleagues in the medical fraternity themselves are not aware of this. And I have a number of times parents coming in at 3 or 4 months. And when I ask them how come they did not turn up earlier, they say my pediatrician, my obstetrician said surgery will be done at 3 months. Please go at that time. So this is something, whether you people who do clefts or not, if you understand that there is an important element of the treatment that should be carried out, must be carried out as soon as the baby is born, that would help us spread the message in the wider community that treatment for the cleft lip starts at birth. So basically, Abhilasha, can you tell us the steps? So we would like to do it as soon as possible, first week, second week, within a month, as Sneha put it. What does this involve, this nasoalveolar molding?
Right,
steps
sir. We start, yes, sir. So we start basically as early as possible because we want to take the advantage of the maternal estrogen, so that we can mold the cartilages very well. So if we have a medical hospital attached with our college, so it is an advantage for us. We get to see the babies 2 days, 3 days post their birth. So it is like easy for us to get the babies and treat them so early. So what is done is basically we prefer taking impressions in the pediatric ICU itself.
So you have to take an impression. So the first step, once you decide to do the nasoalveolar molding, is to take an impression of the upper jaw. Do we do the mandibular impressions as well, or just the upper jaw?
No, sir, just the upper impression.
Just the upper jaw. So this itself, remember, this is a child that is 5 or 7 days old, and you will have to make an impression in a small baby like this. Are there any challenges in making an impression, Abhilasha? Any challenges?
Yes, sir. Yes, sir. We have to take care that the impression material does not flow too posterior, and the baby is like not choked, or the baby does not swallow the impression material. So care has to be taken that the baby is kept in an upright 45-degree angulation position. Apart from this, oxygen and other emergency drugs and everything has to be kept handy that time. And then after taking the impression, casts are made. Based on that cast, you can fabricate an alveolar plate to which a wire part is added. Along with the wire part,
so what we see in that picture, Abhilasha, just a second. What we see in that picture, the pink material is alveolar plate. It's something very similar to your denture base, right, which covers the hard palate, and then there is this wire poking out of it, right? Okay, go on. Sorry.
Yes, sir. Yes, sir. So that wire part, it will now incorporate. You can use an acrylic material also, or a clear acrylic or a pink acrylic you can use, and you can add an acrylic nasal bulb to it so as to project the nasal tip. And now care has to be taken that the bulb should be facing towards the medial of the nostril.
That is the nasal bulb. Okay, right. Yeah, go on.
Yes, and now what we do is just to fix this plate or keep it in proper position, along with the plate, we do lip taping. So what is done is a base tapes are placed on the cheeks of the patient.
And you're using Steri-Strip there? Is that what you use? This is what we have used? Steri-Strip to tape the lip together. And while you're taping, you've also pinched the lip together, right? You're trying to bring them together.
Yes, we want to move the alveolar segment as well. So what can be done is to avoid skin irritation, you can place a base tape onto it, which you can add your horizontal tape, which can be replaced daily. You don't need to replace the base tapes regularly, but yes, you have to replace the horizontal tape daily.
Right. So Pashupati, there are two elements to it, right? There is alveolar molding and there is nasal molding. Can you just tell us how these two different components are addressed? Obviously, Abhilasha has shown a nasal bulb. Can you throw a little more light on how you do the alveolar molding and how this nasal bulb helps in nasal molding as well?
Yeah, the alveolar molding is done by a series of reductions and additions of acrylic as and when the child grows. There are modulations that are happening in the alveolars level, and
so you are going to add material. So you are going to add material in the direction where you're pushing the alveolus and you're removing into areas where the alveolus needs to move, right?
Needs to move. That's right. That's right.
So where alveolus needs to move, you're removing. Where the alveolus needs to move from, you're adding. So gently you are adding material and bending, particularly the greater segment, right?
Basically, just to correct the skeletal deformity that has happened as much as possible by guiding it, because there is no muscle guidance here. That is why the skeletal deformation has. So the concept of alveolar molding is that you need to guide it into a favorable position.
Yeah, I will show some casts in a minute after this. What about nasal molding? What is this nasal bulb doing? What is the purpose of this? What is it trying to achieve?
Yeah, the purpose is to achieve nasal symmetry and to provide the necessary columnar support, which would have been if not for a cleft, and to guide it in a way to passively fit the nostril rim so that it molds the nasal cartilage, the lower lateral cartilage, along with the columella. Because there's a hemicolumella shortening, there may not be a actual defect in the columella, but it is just a short columella which is pulled flat.
And what about the lower lateral cartilages? What about the lower lateral cartilage?
That is to basically support and medialize the flattened lower lateral cartilage to a more medialized position in symmetry to the other side.
Okay, so in one word, if you so elegantly put it, Pashupati, that the idea of nasal molding is to get nasal symmetry. I already highlighted all those problems: shortened columella, deviated septum, collapsed lower lateral cartilages, flattened ala, and so on and so forth on one side as opposed to the normal on the other side. And in order to get this symmetry, we are doing this. Let's see how it works in a minute then. Okay, so here is a same child who has undergone nasoalveolar molding now for a few weeks, about 3 months maybe. Sneha, do you want to tell us what are the things that changes that you see pre on the left hand side? That's pre-op, and this is post-nam as it's going on.
Yeah, we do see that the alveolar segments tend to bring the, the alveolus tends to come closer because the cleft width tends to narrow down. Your lip is more in an approximated position, and nose, you see a good elongation in the length of the columella, and you, instead of the lower lateral cartilage that is more slumped, you see that it is more approximated, more closer. So the amount of tension when you do this while surgery, the tension across the cleft is definitely much lesser when you see cases without NAM. So
I think Sneha, you hit the nail on the head. So if there is one single important advantage of doing this nasoalveolar molding, particularly the alveolar molding, is that the cleft segments come much closer together. So the tension at the time of repair is going to be significantly different. And for a cleft surgeon, tension is everything, because if you are trying to reconstruct the muscle sphincter, it may not come together well, or it might break down, or it may scar. Your skin tends to scar more when you have tension. So one important thing that the alveolar molding does is to reduce tension, and then also the symmetry that we spoke of. Right, let's go and see some more. Sorry. Right, this is a series. This is a different patient. This is a series. This is something that we have published in the Indian Journal on management of the unilateral cleft lip, nose, and palate. And this is a picture from that. So over a period of the 3 to 3.5 months that it takes. So remember, we started off nasoalveolar molding as early as possible, probably in the first 2 weeks of life. And then we kept on guiding the alveolus by removing the plate substance where we are guiding the alveolus into, putting pressure from the opposite side, adding on a nasal bulb to medialize the cartilage, to make it rounded, to straighten the columella, etc. And as the baby came back for follow-ups, we tend to do it 15 days, once in 15 days for the first month, and then once a month. It can be little variable. There is an element of burden of care involved here. And slowly, from A to F, you find that what Pashupati pointed out, the symmetry is being achieved. Look at Compare A with F. Look at the length of the columella on both sides. Look at the position of the septum. Look at though the nostril and nasal floor is not yet reconstructed, that happens at the time of surgery. Look at the three-dimensional symmetry that is coming there, getting to a three-dimensional symmetry as compared to figure A. But there is one problem here. I think I've mentioned it already, the burden of care. A newborn baby, 5 to 7 days old, needs to wear this appliance for as long as it can, maybe 24 hours. Isn't that a huge trauma, Abhilasha? Is this something that parents and newborns accept well, or is there a significant hurdle to cross here?
Definitely there is a hurdle, because it is very difficult first to convince the parents that they have to put something in the baby's mouth. So first of all, we need a lot of counseling for the parents itself. And then obviously the parents at times, they are not so cooperative. Obviously the child won't be cooperative. The parents are also not so much cooperative. They don't come for follow-ups. As Dr. Pashupati rightly mentioned, that we need to remove some acrylic part and put some material in the position so as to mold the alveolar segments. But that is not possible if the parents are not coming for follow-up. So obviously it's a big hurdle for that.
Yeah, so
I find it difficult.
Yeah, so adding on our own experience, we started doing nasoalveolar molding in 2007 and have come a long way since. We had a significant dropout rate of about 40 to 50% in the beginning, because we were not doing what Abhilasha called counseling or motivating the parents in a good way. Our team has now learned the hard lessons. Today, before we jump into making an impression, my orthodontist sits with the parents, explains to them, shows them the various processes in the form of a presentation, tells them what to expect, what the hurdles are, how to overcome them. And this kind of a counseling session significantly improves the rate of at which the parent compliance is obtained. Even today, we have situations, this is a big foreign body there. It can be irritating. I get a phone call from one of the patients saying, oh, there's some slight bleeding from the nose. My child doesn't wear it, or my child starts removing this appliance. This is something that can happen. Remember that this takes about 12 to 16 weeks. And as a child becomes a little older, 3 or 4 months, many of these children playfully remove this, or if they're unhappy, angrily maybe, they throw it out. And then the parents find it difficult to put it back again. So that is another reason why you would want to do this therapy at the earliest, because the passivity of the child, if I may put it that way, is much better in the early days. So you can have all kinds of problems. You can have allergy to the tapes, like Abhilasha mentioned. You can see some redness of the lip in many of these, particularly the figure E over there. You can see some redness. You can get some allergy. People use aloe vera and stuff like that. You can have irritation from these wires and flanges. So it's important that you take the parents along. But what I have seen, we have conducted a survey of about 120 patients, and in about 90% of them believe that it was worth doing this, and that they would recommend it to another cleft parent if they were asked. So it is a significant burden of care. It has a learning curve, not only in the technique that you use, but also in involving the parents and the child. But like has been pointed out, in reducing the tension at the time of repair, in making the lip and nose much more symmetrical than when the baby was born, it helps us produce results that are so much better. Let's have a quick look at that before we actually go in. So these are some slides from Abhilasha showing how the alveolar segment narrows. I have something better to show. You can see that in that cast. So cleft widths at the alveolus of 8 or 10 millimeters become 1 or 2 millimeters after nasoalveolar molding. Not only that does the width reduce, but the skeletal abnormality also reduces. Remember what I said, the greater segment is rotated more laterally, and then it moves towards the lesser segment, thereby making the arch look more of a U-shaped arch. It's not just the width of the cleft, it's also the shape of the arch, thereby giving a better skeletal base to the soft tissue deformities. Another slide here also from Abhilasha, which shows how the cleft can be narrowed. Okay, these are on casts. So we go back to our first patient who has now had surgery post the NAM, and this is a few months after the primary lip and nose surgery. Where nasoalveolar molding is done, we generally do not carry out any primary nasal surgery most often, though there are exceptions. And the technique that we use is a modified Millard's. I would like to start off with Varun. Varun, when you have a case like this treated with nasoalveolar molding, how would you go around repairing them?
Yes, we also do a modified Millard, but we tend to address the nose along with the lip repair.
So can you Varun explain to people who don't know much about Millard's repair? So what it involves, the basic principles and how you would do your reconstruction in a little more detail.
Okay, so basically on the cleft side, there is an absence of Cupid's bow. So,
okay, so let me just try and point that out on this picture. So here, right? Yeah. Can you see the drawing I've made? So that is the cleft side you're mentioning. Yeah.
Okay. Yeah. Yes.
Yeah?
Okay.
Yes.
I'll make it a little brighter. Yeah, that's where
Yes,
the
sir.
Cupid's bow is missing, the filtral column. Yeah.
Yes, sir.
Okay.
So you need to bring it down. So what you need to do is logically speaking, you need a rotation. So what Millard does is there is a rotation flap, and once there is a rotation flap, there is a gap, and you need some tissue to fill
Is that a
gap.
rotation? I've exaggerated that. Does that show rotation?
Not much, but the point is from the
Varun,
Yeah.
what I'm asking is that a rotation? I'm not saying that rotation needs to be so much, but is that what you refer to when you say rotation?
to the
Yes.
base of the columella, that rotation comes.
Yeah,
And-
1 second, just 1 second. I'm trying to remove that. Yeah. So when you say rotation, what you're doing is trying to increase the length here, right? Yeah.
Yeah.
Yeah, Varun,
Yes.
you're trying to increase the length of this, right?
And
Edge of the skin. Yeah.
and
Yeah.
you check with the non-cleft side whether there is an adequate rotation. That is whether there is a leveling of Cupid's bow. So if it is not level, you need some sort of back cut.
Okay.
So if just
So
with
what
rotation,
you are saying is on the non-cleft side here, you
Yeah.
do a rotation to increase the length of the skin. Remember, we mentioned that at the edge of the cleft, the length of the skin is shorter. So you are increasing the length of that skin at the edge on the non-cleft side by doing a rotation and a back cut, right?
Yeah.
Yeah. Okay.
So once you have an adequate rotation and the leveling of Cupid's bow, you need some sort of tissue to fill that gap. So there comes the role of your advancement flap.
Okay. So you are
So
advancing a flap
advancement
from this side. Sorry.
On the
So
lateral
you are
segment.
advancing a flap from this side there, right? Like that. So
Yes.
when you rotate, you've created the defect under the nose. Now you're advancing tissue from the other side, correct?
Yes. Yes.
Yes. Okay. Okay. So basically, Millard's repair is a rotation advancement technique, correct?
Yeah.
Yeah. Okay. Go on.
So
Go on.
you have the cleft segment and the non-cleft segment. The main idea is you can't compromise on the vertical height of the lip. So what we tend to see is you need to compromise whether you need have an adequate lateral segment or as well as the length of the lip. So when we operate a lip, the first thing that comes to in your mind is whether there is an adequate lip length. If the lip length is compromised, your repair won't be looking good. Right, sir?
Yeah. Sure.
Yeah.
Yeah.
So
So you have made that important point about lip length. I'll go to Pashupati now. What about the muscle, Pashupati? What about
Yeah, the
muscle repair?
muscle-
So
the muscle.
so Varun has made a very important point that because of the discrepancy in the lip length, etc., if you don't get that corrected, your shape of your Cupid's bow, your filtral column, etc., is going to suffer, and the quality of your repair is going to be bad. So he has proposed the rotation advancement. This is the skin incision, right? The rotation on the non-cleft side and the advancement on the cleft side. But what about the muscles? Isn't that the important part of repair in a cleft of the lip?
Absolutely. The orbicular Azores is cleft. Along with it, it has influences of other paranasal muscles as well, which are actually deformed and wrongly oriented, both in the lesser segment and in the greater segment, where the labial muscles are actually inserted in the anterior nasal spine and pushing it towards the
okay, I'll just mark that out.
side.
Pashupati, I'll mark that out. Instead of the muscles going across like this, the muscle bundles are going around the anterior nasal spine and the piriform rim like that. Correct?
Exactly. That's right.
So you need to detach the muscle from the piriform rim as well as the anterior nasal spine, and then rotate it and recreate the sphincter. Correct?
Absolutely. In the most favorable passive position as possible.
Okay, right. Okay, so we will go to the repair of the nose in a minute because we have something else to talk about later on. But so basically it is a reconstruction of the muscle sphincter. It is a reconstruction of the 3 layers, skin, mucosa, and the muscle. And the incisions that you make to overcome the deficiencies, classically used in a Millard's technique, is a rotation advancement. But if you go back to the textbook, there are so many other ways of getting this length. We will look at the second most popular option in a few minutes when Abhilasha will help us with that. But this is the most popular technique with a lot of modifications. It's not the perfect solution. Therefore, people have tried to modify. So everybody says, I do a modified Millard, but the basic principle is that of rotation and advancement with muscle sphincter reconstruction, and you can get results like that. That's another inferior view of the same patient that we saw. Nasoalveolar molding, and post repair, you can find that the columella, hemicolumellas are almost equal. The septum is more or less center. The nostril shape is and size are almost symmetrical, and people, gifted surgeons, can get this kind of a result without nasoalveolar molding, but the surgical insult will be more significant. We will discuss that a little later. So now we come to a situation where nasoalveolar molding is not done. Remember, there can be a variety of reasons why nasoalveolar molding is not done. The classic example will be in a situation like Sneha pointed out, the patient turns up late. If beyond 4 to 6 weeks, it doesn't work, child may not tolerate, the cartilages may not mold well because of the reduced levels of the maternal estrogen circulating, etc., etc. So beyond a period of 4 to 6 weeks, even if you have the armamentarium, the resources, the skills, you may not be able to do. And in the Indian scenario, a number of patients might turn up late. It's also possible that you need a specialized skilled orthodontist or a pedodontist or a dentist who can do this. And if he or she is not available in your setup, you may not be able to perform this. And then there is also another category of NAM resistance, where surgeons believe that this is a lot of bunkum, a lot of hogwash from dentists, that this is not required, that they have such gifted hands that the demigods that they are, they can do anything. So there is that group of people who say, oh, don't do all this rubbish, get the baby on the table, I do everything. So for these various reasons, nasoalveolar molding may not get done. One of my cases, you see there in the first picture, we are starting nasoalveolar molding. If you look at the nose, you will see all those deformities that I mentioned in terms of columellar slanting, alar collapse, stretching, everything is still there because nasoalveolar molding is not done. Now, I mentioned earlier that when we do nasoalveolar molding, in my hands, we rarely do any work on the nose, though of late we are being a little more aggressive. I won't go to that now. But when nasoalveolar molding is not done, the symmetry that you achieve with the nose on table is not great. And therefore, various types of primary rhinoplasty, as I may call them, or primary surgery for the cleft nose is also carried out at the time of primary lip repair. So what I've put here is a semi-open approach. I shall just describe this before I go to all the panelists asking for their opinion on how they handle their noses with or without nasoalveolar molding. So this is a technique, as you can see, very clearly, nicely described in the British Journal of Plastic Surgery by Phil Chen and his group. So this is what they call the semi-open approach. So once you have repaired your lip, as you can see in this diagram, you make an incision, a marginal incision, or what is called as the infracartilaginous incision on the non-cleft side there. Okay, that is under the skin. And then you do what is called as the reverse U or the Tajima incision. The reverse U or the Tajima incision on the cleft side. The reason for doing this is, remember, the lower lateral cartilages are slumped downwards. You are going to now surgically dissect it and lift it up. And when you do so, there is excess of tissue in the soft triangle, which you would get rid of, and then try to get the nasal domes to be more or less in the same position. This is being achieved surgically. So the Phil Chen's semi-open approach, which we follow, has a marginal or an infracartilaginous incision on the non-cleft side, a reverse U or a Tajima incision described by a Japanese surgeon called Tajima in the 1980s as a measure for treatment of secondary noses, but we use it primarily. And once that is done, you see the dissection has been done. The cartilage is dissected off the skin cover, right, as you can see in this diagram, and then interdomal sutures are passed. So from the non-cleft side to the cleft side and back. So you do horizontal mattress interdomal sutures to lift up the lower lateral cartilages and the vestibule covering it, and then trim off the excess skin and finish off this procedure. So this is what we normally today follow. So if we have to broadly classify the approaches to the cleft nose during primary lip surgery, there are three different approaches: closed approach, semi-open approach, open approach. If you want a fourth one, no approach at all. So you may not do anything at all because you might think that this is too early to operate or your nasoalveolar molding has done the job. But when you decide to work on the nose, you can do a closed approach, a semi-open approach, and an open approach. And what I describe here is a semi-open approach. And I'm sure people in the panel do different things here. Shall I go to Pashupati or Varun for the closed approach? Who's going to take that? The Trishur technique.
I'll let Varun take that, sir.
Yeah,
He's
sure.
in
Varun.
Trishur right now.
Yeah, Varun. Varun, so what is your current approach for the nose at Trishur?
Even with
would you call it the closed approach, Varun?
Yeah, ours is a closed approach. What we have, our trouble is, like, even with NAM, our septum is still not in midline, and there is a large gap, or sometimes even there is a large anteroposterior discrepancy. So we do a closed approach, and we tend to medialize the deviated septum along with our nasal correction.
Right. So in addition to doing the nasal cartilages with a close dissection, you also medialize the septum. I'm sorry, I forgot about that. That's something that I would do in this situation. While we are doing the lip operation, you're separating the septum from its mucoperichondrial layers and centralizing it. Going back to the lower lateral cartilages or the nostril itself, what is this closed approach, Varun? Can you describe that? How you do it?
Actually, we are detaching all the attachments of the lower lateral cartilage without visualizing it.
So you're not making an incision like I showed on the nose. Yeah. So all the dissection is through the incision you made on the lip, right? So that's why we call it a closed approach, correct?
Yes.
Yes. Okay. So you're freeing the cartilages and then holding it in position. Do you put some sutures to hold it in place?
Yeah.
At the end of the procedure?
The Mecum stitches, and so that tends to hold our cartilage in our freed position. But what we tend to see is, despite all that, there is some sort of relapse. So
Okay,
Not
so
only
so
satisfaction,
what you're saying is that the closed approach doesn't solve all the problems. Yeah, okay, fine. We will leave it at that for the time being. We're only discussing primaries today. Anybody doing open approaches here? Completely opening up. This was popularized by someone known as uh, Trott. Professor Paul Sambrook might know him. Trott was an Australian surgeon. Trott and Mohan were the people who popularized this, and then it was C. Thomas, one of our Indian surgeons, who popularized it still further. Anybody in the group who does complete open rhinoplasty at the primary stage?
No.
No. So that's quite drastic. That's something that's not so popular, though there is Trott and Mohan and C. Thomas who have described it, and a few other adherents to that. Okay, right. So we will just move on with the nose in a minute now. Right. So here is another point that I want to bring in. Another nose, non-nasoalveolar molding. Lip has been repaired. You do a semi-open approach. Remember what just now Varun said. Whether you do a closed approach or you do a semi-open approach, you get a decent result at the end of the surgery. But when you see them at 6 months or 1 year, you find that already there is significant degree of relapse. It's true for the closed approach that Varun talked about, and it's true for semi-open approach as well. The reason is that you get the tissues in a position you want. Remember, you have created scars with all your incision and your dissection. As this wound heals, the scar contracts, and you go back to the original position or close to the original position over a period of 6 months to 1 year. So this relapse that occurs during healing or scar contracture is something that is a spoil sport as far as all this previous work you have done. So the current strategy to address that is to use what are known as nasal conformers or retainers inside the nostril for a period, right from the time of surgery, as you see in these pictures, for a period of about 6 to 9 months post-operatively. Now, nasal conformers are usually made of silicone, and these are commercially available. They're expensive. So in the Indian scenario, once again, people may not be able to afford them. What we use for nasal conformers is the nasopharyngeal airways that the anesthetist used to keep the nasal airway patent, either temporarily or for longer periods. This is also made up of silicone. What you see in these pictures is a nasopharyngeal airway whose tip has been cut and who's been trimmed off in the center and folded. This is something that my colleague Dr. Mustafa popularized here, and I picked it on from him. You choose the size of nasopharyngeal airway that the anesthetist would use to get a nasal airway in. So they have their calculations, and then also make sure that it snugly fits the non-cleft nostril. If it snugly fits the non-cleft nostril here, that same size is what you need. Once you have finished all your surgery, you then use this conformer and then fix it in place for the first week, because in the past we used to use this post-operatively, but it's very difficult to insert this thing. This eventually is a removable conformer which the parents put in and take out, clean it, etc. But if you do not place it at the time of surgery, it becomes quite difficult for parents to insert it, because it's quite painful when you try to do it at 1 week's time, because the tissues have collapsed. So currently, this is what we would do. We put one of those Macomb stitches that Varun mentioned to hold this in position. Currently, we use more than this. We use one interseptally and one on the opposite side also, because oftentimes after a few days, it pops out from the normal side. And then we take it out at 7 to 10 days. The advice is for the parents to try and use it for as long as possible. If they can use it up to 6 months. I know a couple of my fellows are in this crowd. They will tell you that this doesn't happen often. Compliance with this is not very good, but I'm quite happy to keep it on at least for 10 days. Would prefer to use it for 6 months. What's your experience, Abhilasha? Do you use these nasal conformers when you do dissection, when you don't do dissection? What's your opinion about them?
No, sir. As you correctly said that it is too expensive, so it was not possible for us to use conformers. But yes, like Mustafa sir once, he showed this conformers, making conformers from the nasogastric, sorry, the oropharyngeal airway. So it is a good
Yeah.
technique. It can be used. As of now, we are not using, sir.
So what is your experience? What kind of nasal repair do you do for your primary noses, and what is your experience with how the results, whether they're stable or not?
So even I follow the closed dissection technique only, what Edinburgh sir used to teach us. And like Dr. Varun mentioned, the results are not stable.
Sneha, do you have a different approach? So we have a closed approach from
I use a closed approach. I approach from below the rotation flap, dissect through the medial crura, go on to the dome, then come from the lateral side, free the lateral cartilage, lower lateral from the lesser segment, and then stabilize the septum, and then put sutures. And I use a bolster, but I do not use a conformer. I have two reasons. One, because of the expenditure, and the second, what I have noted is it tends to crust a lot, and it stimulates more of nasal secretion, which tends to keep dripping onto your suture line of the lip. So I find it difficult to manage a patient if I put the patient on a nasal conformer. Even a bolster, I have noticed that it tends to fall off by 5th day maximum.
I agree with you, Sneha. These are not easy options. I must say that since the time we started using these conformers, it's not been a long while now. It's less than a year. For 2 patients, I've had to remove because there was airway obstruction with which the child was not comfortable. Though it's not a complete obstruction, it's just obstruction of one nostril often. But secretions, little blood clots can cause problems with breathing. And in 2 instances, I've had to take them off. Yeah, these are not straightforward options. But if it was my child, I would try to use it because like has been mentioned by both Abhilasha and Varun, whatever close or whatever type of dissections, that's the problem. Yeah. So we are chasing something which is not easily achievable. That is the take home point.
And the more worrisome part is when there is a lot of nasal secretion pooling on your lip. So you have to keep cleaning it pretty often. These are all things which I'm not sure. If I use a resorbable suture and send the patient home, then I'm more worried that they may not maintain the kind of hygiene that we want. So that is another thing.
And sometimes they may come with crusted secretions, and when you clean the underneath, you find some breakdown, right?
Yes. So I really do not. I have never used nasal conformers, so and when I'm thinking about it, I look at all these options. So I stick on to closed, and sometimes I do a semi-open.
Agreed. You are not as foolish as us, Neha. That's the point. Okay,
let's experience. Maybe with experience, I'll become like that.
Maybe. So we were talking about we were talking about the. Yeah, sure. Well, sorry, Pashupati. I'm not ignoring you at all. Sorry.
No, sir. Can I just add on Trishur? Can I just add on the Trishur experience just for interest? It is not that Trishur never tried the semi-open approach. I was assisting Edinburgh sir in one of the cases, and he suddenly volunteered to do the semi-open approach. I think I assisted 2 or 3 cases with him. And the worry there was to leave behind a scar. It was not a difficult procedure, of course, to leave behind a scar. Then the consensus within the department, along with Dr. Narayanan, was better to leave the skin untouched and then address it later on the preschool rhinoplasty or later on. So that was the concern.
Thanks for coming out with this. Now that you told story, I need to tell you a story as well. I was also extremely scared in making this skin incision, particularly the tajima on the nasal skin for a 3 or 6 month old child. And for a long time, what I did was close dissection. Then, like you guys said, it doesn't work. I stopped doing any dissection. And one day in a Smile Train Surgeons meeting, I presented my work saying, look, you're doing this primary nasal work. It's not predictable. It's not very useful. So I've stopped doing them. And that day, people just shot me down. I barely managed to get out of that hall, including your boss, Narayanan. Everybody said, in this day and age, how can you do it? How can you not touch the nose? So I was talking to Philip Chen. I was in an AO faculty development program, and then he told me, go ahead and do it. Nothing will happen. At that point of time, I was more inclined. So Philip Chen had initially, before starting this Tajima, he was doing only infracartilaginous incisions. You know, those are at least not visible. Though they scar, they're not visible. So I asked him, shall I try both marginal incisions? He said, no, do the Tajima. You will be all right. So I started doing them. Again, like I said, I would like to lie and say that every time my scars are wonderful, but I have already seen a couple of my fellows in this audience. They might start putting comments on the chat. So I will be honest. We do get some bad scars sometimes, and they can be tricky. But overall, the overwhelming majority of patients, I'm happy. I've also evolved. I had some learning curve with the Tajima incision. We can discuss that another time. Okay, so moving on, we said that the rotation advancement principles, let's put it that way, is the most commonly used principle for repair of primary unilateral cleft lip. But the second most popular technique is what is known as the triangular flap or the Tennyson-Randall technique. And there are people like Abhilasha who, though they do Millard's repair most often, in certain situations where they think that the Millard repair is not the right option, they do Tennyson and Randall. And then there is other group of surgeons who do only Tennyson and Randall. So I would now like Abhilasha to take us through these slides of hers of when she does these triangular flap techniques and what are the principles of doing it and the advantages. Abhilasha?
Yes, sir. Thank you, sir. Like Dr. Varun mentioned about the deformities or the discrepancies in the cleft, the medial element wherein the length of the lip is not appropriate. So like the Millard, we have a rotation flap, but in case of triangular, instead of the rotation flap, which is hidden under the columella, here we have a straight scar or an incision on the body of the lip. On the lateral element or the cleft side, we have an isosceles triangle or an equilateral triangle. The initial technique
is that the triangle you're talking about? I'll try and draw that.
Yes, sir. Yes, sir.
Triangle,
yes, sir.
there. Yeah. Okay. You're taking that triangle from the lateral lip element.
From the lateral lip element.
Increase the length of the medial lip element, right? Which is short.
Yes, sir. We have given
instead of a rotation,
the...
you're doing a triangle here, right?
Yes, sir. So medial element, we give a back cut. You can see a back cut here, sir.
Mm-hmm.
We have a back cut here, which open ups. So the lip element on the medial side, it lengthens up. Right. Now, as Dr. Varun mentioned, in cases of Millard, we need to put some tissue in that gap. So similarly, in case of triangular, we measure the dimensions. Like the initial method was given by Tennyson, which was further modified by Randall, wherein he reduced the dimensions or the length of that triangle so that the scar with a horizontal scar, which we see on the body of lip, can be of a smaller dimension. Though it does not look good, it's not natural.
So where do you use this, Abhilasha? I thought you normally do Millard. So when do you use this triangular flap? What are the cases where you use
doing this? Yes, sir. So I prefer doing this triangular technique wherein the baby has not undergone NAM and the baby is having a wide cleft lip. Like in this case also, you can see when the baby came to report it to us, already the baby is having deciduous dentation. This baby
it's an older child.
She was, yes, sir.
Yeah.
So in those kind of cases, I prefer doing triangular technique because I feel with Millard, I get an up pulling of the scar and again,
so vertical shortening or notching, right? Yeah. So yes, that's why in a wider cleft, if the child is older or if you see a much older man as you have in this slide, these are the situations where you use the triangular flap. Now,
yes, I've specifically put this adult patient here. I know we are now discussing only on the primary procedures, but we do get patients wherein they were like not aware of the procedures or the treatment which are available for them. So we do get cases like this also. He was 50 years old when we got him from some camp.
Yeah. So yours is like a horses for courses thing where if you find older patients, wider one where you think that your results with Millard will be inferior, particularly vertical shortening of the lip. That's when you use.
Right, sir.
Okay. Let's move on. For want of time, we can go on for a long time. We go on to the bilateral cleft lip. I just want to give you a brief remit of this case. This was a patient who had a bilateral cleft of the lip, who went into a mission surgery, and they operated on him, and it completely broke down, and he came to me. This was in 2008. He's 12 years old now. So he was not an ideal case on which to start a nasoalveolar molding, because he was already a little older. He already had a breakdown, but one of the problems in the bilateral cleft lips is the protruding premaxilla or a premaxilla that is deviated. If you see this side here on the right hand side, you find that the premaxilla, instead of being in the center, has deviated, and it's actually overlapping a part of the lip. So a protrusion of the premaxilla in anterior-posterior direction, a deviation of the premaxilla makes it very difficult here to get good repairs. Also remember, there is no muscle. There is no muscle in this prolabial segment. One big important difference between unilateral and bilateral, other than the protruding premaxilla, is that all the muscle are in the lateral segments here. And when you repair, you have to get the muscle from here across the midline. And this can be a very difficult process, particularly with a protruding premaxilla. So nasoalveolar molding is something which is much more important in a bilateral than in a unilateral case. Do you guys agree?
Yes.
Yes, sir.
Yes, sir.
Yes. So this was a child who underwent nasoalveolar molding. Sneha, do you want to comment on the differences between nasoalveolar molding in the unilateral and bilateral? Is it much different, or is the principle same?
The principle tends to be the same. So you again have an alveolar molding plate with the nasal stents that's going to come up, which is stabilized across with plaster tapes or your steady strips across the lip segment. And you tend to increase your nasal component, the height of the nasal component slowly, which is more medially placed, so that you get the columellar length, and then also mold the alveolar segments. But the only problem is when the premaxilla is trying to get pushed back, you should have adequate space between the lateral segments for it to be accommodated. That is one thing. Or it may just completely rotate backwards. So,
okay. So what you're saying is, though our aim is to push the premaxilla back, there should be enough space in the arch between the two lateral segments for it to move backwards. Occasionally, that could be a problem.
yes.
Yes. And the other issue is, as compared to the unilateral, here the columella is completely absent. It is not a hemicolumellar deficiency. It's a complete columellar deficiency. So as you lift the lower lateral cartilages on both the sides, you can see nasal bulb on both the sides. You stretch the columella as the lower lateral cartilages go up, right?
Yes, sir.
I have found that skeptics of nasoalveolar molding, the partial skeptics, they sometimes say, okay, if you have to do it, you should do it for bilateral, not for unilateral. So that's where we are. So here he is 3 months later. This first picture was 2008 November. And in February, we managed to do this, get some amount of columellar show, get the premaxilla more to the midline, as you can see in this picture. Remember, this is a person who's already had a primary surgery and breakdown, not your regular child who came in the first week, but we applied the same principles. But we do it for all our bilateral cleft lips once again till presenting time being 6 weeks after being born. Beyond that, like all the others have pointed out, it's not usually possible. But again, tension was the word somebody used earlier. Reducing the tension at repair is extremely important, and in the bilateral it becomes much more, because as I pointed out earlier, the muscles here have to come from there and join together. Unlike in the unilateral cleft lip where they're much closer together. All the muscles are now bunched together near the pyriform rim there, and then we need to free them and get them under the prolabium. And this can be under a lot of tension if the premaxilla is jutting too far forward. And I would like to just show this chap after his repair was done. Oh, sorry. This is the cast, similar to, this is not the same patient, it's a different one. You find that initially the premaxilla is there. So that's a difference and now premaxilla is here, almost closing the gap, right? So premaxillary setback has occurred over a period of 2 or 3 months. This is pre-NAM and that's post-NAM. Remember what the point that Sneha made, that if there is a collapse of these two arches, then it may be difficult to push this premaxilla backwards. It might stay buckled to the lateral segments. That is one of our concerns. So this is
Sir,
an
can
example.
I come in, sir?
Yeah, sure, Abhilasha.
Sir, in these kind of cases wherein Dr. Sneha mentioned, what we do is we try and expand the lateral limits and then try to bring back the premaxilla.
With
This
the
is done
nasal,
during NAM
with
itself.
the nasal appliance,
Yes, sir.
yeah,
Yes,
with the
sir.
same appliance.
Yes,
So
sir.
with the same appliance,
same
you try
appliance.
to expand the lateral segments a little bit. Same
Yes, sir.
principles, probably adding on the inside and removing on the outside, pushing the lateral fragments
yes,
a little
sir.
bit. Yeah, yeah. So you could, what you're saying is you can do an expansion in an infant of the lateral segments as you push the premaxilla backwards.
But does this happen after 2 months, or you need to go with a Latham appliance or something?
Abhilasha? Abhilasha, the question is, if a child is seen after 2 or 3 months, will you be able to do it with a NAM appliance? Maybe we have lost her.
Yeah.
Abhilasha, are you there?
So her screen is frozen, so I think she's
Yeah, okay. So we will move on. We'll ask her this question a little later. So here he is at the time, now in 2010. So his lip and palate have been operated. What I want to show is that you get a decent harmony of the lips when you have the underlying skeleton in a better position before surgery. But we will also discuss a few principles of bilateral cleft lip surgery. Who wants to go? Pashupati, your principles of operating the bilateral cleft lip?
Yes, I would tell my Thrissur experience to start with. We had actually evolved from the basics where we just tried to do Rose Thompson straight line repair, wherein we did not bring the muscle to the prolabium for many number of years. And then slowly, I think we are moving to bringing muscle into the prolabium. Another important concept is to keep the mucosal aspect of the prolabial mucosa down and not keep it with the skin. That's because if you keep it with the skin, I think it shows a lot in the post-operative period, and it is not very aesthetic, at least to many of us. But some surgeons do follow this and find it easier technique to do, and they don't find it that unaesthetic. But overall, it is again, the principle is the same, to release all the orbicularis oris muscle from the perialar side, and then mobilize it medially, and then fix it under the prolabial skin, and do a 3-layer closure.
What about the nose?
The nose, as Malikan points out, one can probably do a open structure, but I have not ventured into that personally. So I don't do a closed nasal dissection or open nasal, semi-open in the bilaterals so far.
Right. This is, so we will discuss palate and speech in a bit for continuity's sake. But this is my patient Mohammed Omar. He's now 7 years of age. You know, the same kid who had the broken down lip after first repair in 2008. Now he comes to us with the collapsed arch, as you can see there, you know, with the premaxilla buckle, the situation that Sneha has described. And now is also time for him to undergo a bone graft in a year or so. Very briefly, we will discuss these principles of alveolar bone grafting. What is your approach in someone like this, Sneha?
Sir, in this kind of cases, I would ideally always say first orthodontics expand the arch nicely, because it increases your comfort of dissection and suturing the palatal layer, especially when you're going from the labial side. If you have collapsed arches like this, it is virtually, I find it really very difficult to dissect.
For the bone graft, you mean?
For the bone graft.
Dissecting the tissues at the time of bone grafting.
Bone graft. So getting good expansion, and after that you can pack as much bone as you want. And in case if you have a post-alveolar fistula, that is another thing that is very common. It happens when we do a single stage palatoplasty, as you mentioned yesterday, sir. In that case also, I think post expansion, though the fistula is big, I would opt for a tongue flap and then do the bone grafting. Without expansion, I would find it difficult.
Okay, so when you have someone like this, bilateral or unilateral, where there is collapse of arch, overriding of arches, you would do an expansion before bone graft. It is possible to do bone grafting without expansion, but yes, like Sneha very clearly mentioned, so much of crowding, overlapping of tissues makes a comfortable and good bone grafting procedure difficult. So you go ahead and expand him and you get things like this. Now you can see a small little fistula there on the behind the premaxilla, right, Sneha?
Yes, sir. Yes. But is it a functional fistula, sir? That's another thing that comes up. So
yeah, in this case, it's not functional. Let's not go there, because then we may digress, but it could happen. And then you may have to treat the fistula like you mentioned. In this case, it was not, but the limited point here is that before you do bone grafting, you may have to expand the lateral arches and then get the premaxilla into a right position so that your pre-graft arch position is comfortable or optimal for bone grafting. So he underwent bone grafting, and he was in the clinic a couple of days back. My orthodontist is working on him. Mohammad Umar is now 12 years old. I just put up this series of slides while we discuss primary cleft surgery, just to say that unlike many of other things that we do, maybe dental-alveolar surgery, maybe orthognathic surgery, maybe benign pathology, etc. These are children who need to be followed up for a long period of time, from the time they are born till they become adults, 18 years of age, at different stages. Though, like I mentioned, this is a panel of surgeons. Management of these cleft lip and palate deformities is truly interdisciplinary, and you need other people to come in and work at different periods of time: orthodontists, speech and language pathologists, ENT surgeons, psychologists, and so on, geneticists, and so on. So it's extremely important to remember that if you want to give good care for your patients, you should build up teams, and the teams might have to consist of various specialists working together and planning for making these children lead a normal life. That is one limited message I wanted to put on. Now we'll move on to the palate. This is
can I just ask one question, sir, before we move on?
Sure. You are supposed to answer questions, but you can.
Sunny, just follow.
I'm joking.
Just I wanted to know, in cases of bilateral cleft alveolus, do you prefer grafting both the sides in the single sitting, or you prefer doing it one by one?
Okay, this is a very good question that quite often people wonder, because of the problems of scarring of the tissues, the fear that you may not be able to get good tensionless soft tissue closure if you try to do bilateral bone grafting at the same time. There are people who might do grafting on one side and do the other side 3 to 6 months later. That was the practice that I too followed in my formative years, but I have realized now that I can avoid an additional general anesthesia, an additional time of bone harvesting in all instances. And today I routinely do bilateral bone grafting at both the sites at the same time. But having said that, if you have the reluctance, if you think you are not sure, there is no harm in doing one side at a time. But from a patient's comfort point of view, it is one less GA. Otherwise, he'll have pain in the hip twice, and so on. So I prefer to do it. It can be a little dicey, but always, when you advance the buccal soft tissues, you are able to get closure, and whatever may be the situation, you are able to nicely advance your buccal flaps from the lateral segments and close your bilateral cleft. So I don't usually have a problem. So we move on to the palate, because after this, we also have to take questions. Cleft palate is another ball game. I put this picture of an older patient because it's easy to take these pictures of the post-op. In children, to get pictures like this is difficult, that's all. There are a number of issues that we would like to raise very, very quickly. One is, what is the timing at which you do cleft palate repair? I'll go with Varun. What is the ideal age to repair the cleft palate?
We repair palates at 1 year actually. Initially, we used to do it 11 months. And in cases where you have parabin or respiratory issues or any other comorbidities, we operate at 1 year, 3 months at max. So
right.
We close.
Yeah, so we'll stick to the timing for the moment, Varun. Pashupati, your ideal timing for cleft palate repair?
Ideally, it should be done before the babbling starts, probably 8 months. But due to various reasons, the size of the cleft defect and the thickness, the muscle thickness, the soft palate, everything. I think it is better to do it anywhere between 9 months to 14 months, I would say.
So what you're saying is you should not delay it. Within this year, around 1 year of age, it should be done for most people.
That would be ideal. That's right.
Yeah.
For better speech.
For speech. More you delay, more problems with the speech that we met. So what we must remember is that one very important thing that is related to repair of the cleft palate, functioning of the palate, is normal speech. So the goal, though there are various other subsidiary goals, the main goal of a good cleft palate repair is to produce good speech. And all the things that we are going to talk about, timing, about technique, about staging, the controversies, all mainly revolve around speech, but also the growth of the maxilla, which is the second important point. So Pashupati is making a point that from the point of view of getting good speech, you can't delay beyond 12 to 14 months. Earlier the better. As the child starts speaking, it should have a structured functioning palate. Sneha?
So 1 to 1.5 years maximum. I don't do earlier than 1 year, but 1 year to 14 months, yes, definitely I would.
So more or less very similar, right? Around a year of age. So as usual, we are a little more aggressive people, maybe because of more gray hairs that I have. We've now started operating palates for the last 2-3 years at 9 months. But like Pashupati mentioned, one of the important things that I look at is the availability of tissues in terms of width of the palate, the weight of the baby, etc. And we have a cutoff. We have a cutoff about 7 to 8 kgs. If someone at 9 months is less than 7 kgs, we usually differ. The 7 kg is no magic, but it's just an arbitrary number. But what I'm trying to say is that if we think that the bulk is not adequate, if it's a very wide, we might delay it, but never beyond 12 months unless there is a significant systemic problem. Right. So that is for the timing of repair. Now, another big controversy about cleft palate is staging. Whether you do the palate from the uvula to the alveolus in one go, whether you do it with the lip, whether you do it separately, whether you do soft palate first, hard palate first. There's so many different philosophies that exist. The reason is that growth. A lot of children who have primary palate clefted and repaired tend to develop maxillary hypoplasia, and all these timing and staging techniques are trying to address this issue of growth. So everybody has his own favorite method of getting better growth, which has resulted in various combinations of this procedure. So let's see what our panel does here. We will start off with Abhilasha. Abhilasha, how do you repair your palate in terms of doing it in one stage or 2 stages, doing half first, front half first or back half first? What is your approach?
In cases of isolated cleft palate, we prefer doing it in one stage. But yes, in cases wherein we have a complete cleft lip, alveolus, and palate, what we do is, along with the lip repair, we repair the anterior palate part using the vomerine flap and the nasal layer, so as to avoid future fistula formation. Okay, so this is very a common, very popular, very common method of repairing the palate. You do the hard palate repair, single layer vomerine flap closure, also called as the Oslo technique, along with the lip. This is something that is very common around the world.
and then do the secondary palate or the soft palate at what age?
So again, 10 months to 1.5
Yeah,
months.
sure. Yeah. Okay. Sneha, what is your approach for the palate in
So
terms
I
of
do
staging?
a single stage 2 flap with IVVP.
Okay, so you do lip and then you do palate as one stage, right?
One stage,
so palate from front to back at one stage rather than doing anterior palate at lip repair. So this is the also another popular approach where you do full palate in one stage. And the Trishur boys, anterior palate.
No, we do the lip repair. And the anterior palate, of course, is, Dr. Vasant has been doing it for many number of years now. But I would like to stick on to the lip repair, wherein the nasal lining is definitely addressed beyond the alveolus, but it is not inserted under the palatal mucosa, which is
You're not doing the hard palate, complete hard palate, single layer. So you like the Sneha's approach of doing one stage.
Yeah, I like to do it with one stage. Yeah.
And Varun, the current Trishur practice is to do anterior palate as well, hard palate as well with the lip.
We still carry on both routes actually, but the key inform thing is like to repair just behind the alveolus so that we avoid the fistula anteriorly. So that
so Varun, why both the approaches? So how do you decide whether you do full hard palate or not do it? What are the criteria for that?
If the NAM is done and all, then it's okay. We can do with without vomer flap. So it depends on the width. Yeah, and the
so if the cleft width is narrower, nasoalveolar molding has been done, then you just do the lip repair and the palate repair separately. But if it's a wide cleft, then you might do a lip with anterior palate. Okay, is that the approach?
Yeah, thanks.
Yeah. So you see, there is already so much of divergence coming up. There's not much debate about timing, but about whether you do anterior palate with the lip, whether you do palate completely together is something that there is divergence of views, both from the point of view of speech as well as growth. But I have looked at what do. We do a single palate. That is the two flap Bardak's philosophy, which Sneha and Pashupati advocated. However, my colleague Dr. Preetham Shetty was trained to do the anterior palate, and occasionally I find him doing that. I think his logic is the same as that Varun mentioned. Sometimes when I'm doing the secondary palate, I find that he's already repaired the hard palate for that case. And when I ask why it was done, it's usually because it was too wide. So he has converted to a single stage palate most of the times like I do, but there are instances where he uses that. So you also find from this that sometimes you may have to use a horses for courses approach, alter your technique based on the type of deformity you have rather than being dogmatic. And one important thing that Sneha also mentioned, she mentioned the word intravelar veloplasty. One of the important components of cleft palate repair, whatever you do, whether you do it in stages, whether you do it early, little later, etc. The common thread today is to do a good muscle repair, and this was popularized by Brian Somerlad. Today, some people even call it as a Somerlad repair. So what is it that we are looking at after the palate is repaired? It's not that the palate is closed, the cleft is closed, but how well it works. And here is just a slide to just tell you what should be the goal in all the cases of cleft palate that we operate. I'm putting in a sound audio clipping of a 3-year-old child, mind you, a 3-year-old child for whom I had done a cleft palate repair.
Re ga ma pa dha ni sa ni dha pa ma ga re sa re re ga ma ma pa pa dha dha ni sa ni dha ma pa pa dha dha ni sa re ga ma pa dha pa dha ni sa ni da ba dha pa ma ga re.
I think you get the drift. So this does not happen always. There are various factors that determine whether the child can speak normally. In this case, she's just 36 months as she sings this. Very aggressive patients who are worried that her speech will not be all right. we were discussing this yesterday, and Sneha, do you want to give your thoughts on what you were saying yesterday? What you consider most important for a successful speech after cleft palate repair?
So the speech that you have shown is a dream of every surgeon who operates a palate. But often I feel that, it is so difficult to achieve this one, because you do a surgical repair, but how much of that surgical repair is actually retained? There are so many factors that come into it, where the technique that you have used, the muscle repair, and the post-operative speech therapy, that is very important, because though you do a good muscle repair, until unless it's given enough physiotherapy, I think getting a good velopharyngeal closure becomes difficult. So therapy becomes very important. When I look at speech therapy from what I'm doing right now, once the palate is done, I call the child back only after 3 months. We review the palate once the healing is good, and then we start putting them on some vegetative exercises. This I've learned from one of the speech therapists when I was getting trained. She says that, okay, you cannot make the child talk when he is 1.5. Okay, but what we can do is we can train the muscle that is there. So you do a lot of vegetative non-speech oromotor functioning. I tell them to, start using a straw. I mean, by 2 years of age, they see their parents, they can use a straw. So using a straw, trying to blow through the straw, and, with pieces of paper, you encourage them, you blow so that, the papers have to get dispersed. I ask them to blow on balloons. This is the initial phase up to 3 years, how I try training. And after that, my speech pathologist starts doing the therapy, and we continue until almost 5 years of age. So that is what I'm following right now.
Right. So Sneha, all my patients can't unfortunately speak like this. One of the things that I find in patients who are well educated and motivated is that the stimulation that they give to speech, first to the language and then to speech, is extremely important, and I find that very useful. I come to that in a little while, but I will also show you what is the end goal, how we assess cleft palate repair if there is a doubt that it is not functioning normally. The go-to assessment, other than the perceptive speech assessment done by the speech pathologist, is a video fluoroscopy. I will just run this slide for a quick few seconds.
Pa pa pa. P p p.
You see the soft palate there going and touching the posterior pharyngeal wall. Okay, so when we talk what are known as oral pressure consonants, that's what should happen. The soft palate moves up like a screen and goes against the posterior pharyngeal wall, doesn't allow air to escape, particularly when we are speaking pressure consonants like p and b. And you saw how beautifully Diljot's daughter did that. So very clear. So when we develop consonants, the soft palate has to go up, as you see in this still picture, block against the posterior pharyngeal wall, so that the mouth becomes a closed cavity, and then you let out the plosives like p, b, sh, s, etc. And this is the goal of any cleft palate surgery, but it does not happen. We are not discussing secondary cleft surgeries or speech surgeries here, but this will be my last slide before we finish and take questions. Like Sneha already alluded, you need to have a speech pathologist coming in our center. We let the speech pathologist see the patient just before palate repair, or failing which 1 month after palate repair. One of the important things that the speech pathologist assesses initially is the language development. Don't forget that. You see the first line, till 3 years, it's language development. So in other words, if the child does not understand the language, he cannot speak. For example, if someone can't hear, they will never speak. We know that if you're deaf, you're going to be dumb, because if your brain cannot process that language, it cannot lead to speech. So initially, as the speech and language pathologists, that's what they're called, SLP, speech and language pathologists. Initially, as the child comes in, we do it 6 monthly reviews. They not only encourage the parents to stimulate talking, talk in front of them, particular type of words and sentences, stimulate the child to speak, and they also assess language development. Oftentimes you will find that there is a little delay in these children, that their language development is not as fast as the other children. Therefore, their speech development may also be delayed. So that is what they do till 3 years. And once it's 3 years of age, in the regular follow-ups, they start looking for articulation and resonance, etc. And if the speech therapist, in addition to doing the therapy that Sneha mentioned, if they find that there is something wrong with the speech, even after they try to correct, then they start looking for a diagnosis of whether the velum is not functioning normally. I showed you the video fluoroscopy. That was a normally functioning velum. In a velopharyngeal dysfunction, the soft palate will stop short of the posterior pharyngeal wall with a gap as we speak the oral plosives, leading rise to articulatory errors, to resonance errors, and so on. And that is the time when this child becomes a candidate for assessment of VPD and corrections, which we will not go into. So basically what we have tried to do today is to try and cover some aspects of primary management of cleft lip and palate. We discussed the feeding issues in a newborn child. We looked at the pathology with which the primary lips present. We talked about the pre-surgical strategies, particularly the nasoalveolar molding, and we also discussed some principles of surgery, both for the primary unilateral and the primary bilateral cleft lips. We also did some discussion about the continuum of care and how orthodontic support will be required even before bone grafting. We also looked at presentation of cleft palates, looked at some of the issues that are important in primary management of cleft palate, including the timing of surgery, the staging of surgery, the importance of muscle repair, and how to assess results after cleft peak surgery. I will stop sharing my screen, and then I think we can go to the question and answers. So I have a few questions that have come up here. I'll quickly start off with this. We have a few minutes more. Once we take these questions, if anybody else has questions, they can add on. So the first question is from S. Gaur. And good morning, sir. Question to Dr. Krishnamurthy. He said in a cleft lip baby, breastfeeding can be done. How will the negative pressure be achieved? Is this achieved by the gum pads? Yes. The lip seal is not required to develop because the nipple is behind the alveolus. You're right. So this is something that can be easily done, and even in complete clefts of the lip, they are able to do breastfeeding. There's some echo now. Okay, I go to the next question. Jim, there is some echoing.
I think two devices are on, I guess.
Not mine. Okay, we'll go on to the next question. Yeah, Jim?
Yes, there is some echo because somebody has got two devices.
Yeah, can someone switch off his second device, please?
Or others can mute when you want to answer, you can answer.
Yeah, so can you please mute then, and then I'll ask the question to specific people. Okay, mute please. Yeah, so I'll go to the next question from Stella Tampi. How do we prevent the ulceration caused by the NAM, especially over the palatal region or upper sulcular region? Abhilasha, you want to take this? How to prevent ulceration by the plate? Yeah.
Yes, sir. So basically what we do is we give a soft liner kind of thing on the plate,
right?
And plus
so
we don't extend the plate up till the soft palate.
Okay, so soft liners are used to prevent ulceration, and then if it actually occurs, then you can look for any spots that are rough or whatever and smoothen it. But main strategy is to use a soft liner and not to extend it into a soft palate. Okay, right. Stella also has this question. I'm sorry, we won't be able to answer this. Could you please kindly show us how do you take the impression in the newborn using? What I can do, Stella, is if you contact me over my mail ID. I will put that up. I can send you a short video of that. I will, maybe we already have it. Otherwise, I'll request my orthodontist to do it and send it to you. I'll get that done. So just email me at kbanantaya@gmail.com. I'll put it up if I can now. kbonantaya@gmail.com, and I can share a video for you. Right. There's an anonymous attendee saying, does muscle memory play any part here? How about relapses? I'm not sure whether we are talking here about the lip, the nasal muscles, or whatever. Pashupati, muscle memory play any part in repair of cleft lip and palate and relapses?
You're muted, Pashupati. You need to unmute.
I'm sorry. Yeah, I think the question is pointed towards NAM and then its memory, or surgery.
Yeah, so you have to now assume that because it's an anonymous attendee.
I think we can answer the question in two ways. One, if you do NAM and then probably delay the surgery and don't continue on NAM, then probably it will go back. It will definitely relapse, I'm sure. But after the surgery is done and the stress again is tension-free closure of tissues, then it minimizes the scar and hardly relapses.
Okay, I must once again say I'm really flabbergasted. We have 255 people now. When I started sharing screen, we had 160 people. Amazing. I never get an audience for cleft like this. Okay, the next question. Dr. Muhammad Anif. Will the long-term placement of nasal conformers cause septal necrosis? No, is the answer. The material we use is silicone here. Number one. Number two, you have to choose your size correctly. If it is if it's too big a size, it might do so, but silicone usually is much more gentler on the tissues. For example, someone who has got a Pierre-Robin sequence and has problems in maintaining the oxygen saturation, one of the things that is done as a conservative method of treatment, if positional semi-prone position doesn't alleviate this, is to put in nasopharyngeal airways. And these nasopharyngeal airways are kept for months together in a newborn, and generally they don't cause this problem. But two important things: make sure you're using a soft material like silicone and not something harder. Also, that the size that you use is not too tight. Mail IDs, please. Jim, will you be able to provide this mail IDs?
Yes, sir. I will do that, sir.
Yeah. Okay. Santosh is also asking for it. Anonymous attendee, delay type of lip repair. Do you consider functional repair? Before I ask the audience around, I mean the other panelists, functional repair does not belong to Delaire alone. That was just a marketing strategy. I'm sorry to be a little blunt. So when Delaire came up with this technique, it really, except for some kind of nasal muscle repair, it's very similar to a Millardian repair. But he did a lot of research on musculatures, areas of mucosa. But to say that Deleuze is the only functional repair is just a marketing gimmick. I'm sorry. But if anybody has experience on the Deleuze type of repair in this panel, they can answer this question. Sneha? You are muted, Sneha.
Sir, what I have read is Deleuze does not have a definite incision line. You know, it mainly concentrates on getting the muscle back into place.
The incision is exactly like that of the Millards, Sneha.
Millards,
exactly like that of the Millard. Yeah.
So I really don't understand. When
without the back cut. Without the back cut.
So it does not become functional because all types of lip repair that are done today have to get the muscle in place. I think because that is the key for success. Delirious. Sir, and one point about the muscle memory that we were talking about. I'm sorry if I can take a minute.
No problem. You can. Sure.
Muscle does not have the property of memory as far as I know. But what happens is if you delay, post NAM and you leave the muscle, it is the buccinator constrictor ring that tends to, take over, and then it keeps widening the segment. So muscle repair done well does not cause any problems. So the muscle does not have the property of memory. It is a cartilage that has a property of memory. That is what always tends to go back into its position.
Right.
I don't know if you agree with me, sir.
I agree with you, Sneha, that cartilage is the one which has this notorious thing to relapse, elasticity and memory, as you might call it. It'll go back to where it was. You're right. We'll go to the next question. What is the basic difference between Millard and Tennyson? It's basically in the incision. If you remember, at the edge of the cleft, on the non-cleft side, the skin is short. We want to make it longer. So you can make a rotation like I drew earlier and lengthen it, or you can do a back cut down and insert a small triangle. So the main difference between Millard and Tennyson is in the incision. The objective of lengthening the skin or dropping the Cupid's bow, as Varun pointed out. Pashu, question for you. What is the feeding protocol for post-op palatoplasty and their justification?
For post-operative?
Yeah.
We
5 minutes.
because
Yeah,
we
go on.
operate on children who are probably 9 months to 14 months. They are still feeding milk, and
Okay.
we of course don't go back to breastfeeding. We are cautious. We advise post-operative phase to give spoon feeds for the child. It can be milk, it can be a kanji type, rice kanji type, for nearly 2 weeks, 2 to 3 weeks, and only then get on to semi-solid kind of a diet.
Right. Okay. So
The importance is to keep the palate clean and not have food debris going and getting stuck in tissue spaces, which are sometimes.
How do you
open.
do that? How do you keep the palate of a 10-month-old baby clean?
Simple way is after every feed to give 2 or 3 spoons of water.
Very good. Okay, we move on. Once again, Dallaire has come in. Sir, Dallaire principle can't be used for reducing the distance between the segment instead of NAM, sir. Thank you, sir. Yes, it can be. Again, it's not just Dallaire's principle. Let's say you don't do nasoalveolar molding, you do the lip repair, the muscle reconstruction itself will push the fragments back. If you don't do nasoalveolar molding, you know, from the time of lip repair to palate repair, the alveolus has molded itself. But remember, this alveolus not molded at the time of the surgery. Sneha wanted less tension in the closure. We wanted the muscles to be together so that it doesn't fibrose, it doesn't become dysfunctional. So post the kiloplasty, whether you do Dallaire or Millard or Tennyson or Krishnamurti or Pashupati's technique, this molding will occur. It's not, I'll tell you, it is not the sole prerogative of Dallaire. This, sir, I don't know your name, is mainly marketing gimmick. I'm sorry. It happens with all, because the muscle tends to push. Remember, why did this deformity occur? Because at 8th week of intrauterine life, the muscle did not go and join. It went in to the anterior nasal spine and the piriform rim. The muscle was not there. So the skeleton moved forwards. Now, after birth, at whatever time you do the lip repair, you're bringing it back together. That will gradually cause the alveolus to mold. No doubt about it. In fact, we have looked at it, and numbers also I can tell you. Between lip repair and palate repair, in 30 of our cases that we looked up, there was 50% reduction without doing any nasoalveolar molding. But the advantage of doing alveolar molding before the surgery is reduction of tension. And remember, we are also talking about nasal molding. I showed you all the effects of the changes in the ala, the nostril, the columella, etc., that can be done non-surgically. This is one of my own fellows. What can we do if the patient returns after a week of NAM treatment with mucosa ulceration and skin irritation to the taping? I think, Sibasis, you should ask this with Renu tomorrow, but I will try to answer. You just give some emollients. Yeah, ask them to stop the tape for a few days. Like Abhilasha said, you can put a base tape. What Renu prescribes is aloe vera gel, but you can ask her tomorrow. Okay. But dissection is up to the zygomatic arch. I don't know what this is in reference to. I will ignore that. Kiran Kumar is asking this question. 2 days old child with cleft lip and palate directly visiting. Then what are the series of events to do with ideal time limits? So as we mentioned, first you have to make sure that the baby can feed. Make sure feeding is fine. It's extremely important. You might be a surgeon, you might be an orthodontist, whoever you might be. If you don't allow the child to feed well, that child is not going to have a good future. Remember, 90% of your brain development postnatally occurs in the first year of life. And at that point of time, the child doesn't receive good nutrition, you are screwing up the child life forever, whether you do a good cleft lip or palate repair or not. So first thing you address is feeding, like we discussed. If your setup has facilities for pre-surgical orthopedics, do the nasoalveolar molding, lip repair at 3 to 6 months, palate repair at 9 to 12 months, speech assessment and therapy, as we mentioned, bone grafting at 9 to 12 years of age. Today, we are also trying to encourage parents to wait a little longer and do a lip and palate repair at 9 to 12 months in order to reduce the number of procedures, primary procedures, from 2 to 1. So given a choice, if it is my child, I would do nasoalveolar molding, wait till the child is about 7 to 8 kgs, do the lip and palate together between 9 to 12 months. We are doing that. There is a bit of resistance on that idea as well. Is there any specific criteria other than wide cleft lip to opt for Tennyson, Randall, or Millards? Abhilasha? I'm sorry, we are
No, it's not like
running out
that.
of time.
Basically,
So sorry, Abhilasha.
surgeon preference, nothing else.
Surgeon's preference. Okay, let's go on. Once again, Tennyson, Randall, better than Delaire. Which of them is superior? Sir, Delaire is the best, sir. Let's move on. Can we expect the maxillary growth in CLP since the sutures are disturbed? Yes, maxillary growth is always a problem. Whatever technique you use, this is the reason why so many different protocols, approaches have been tried and tested. One of the problems with cleft lip and palate is that your results are known only for growth, etc., are known only after 10 to 15 years. So it becomes extremely difficult to do controlled, randomized, prospective trials and significant evidence as to whether Delaire or Millard or single stage, double stage anterior palate is better. Therefore, the question continues. But in general, it can be said that if you operate on a child on the lip or the palate at a very early age, as we do at 3 months, 6 months, 9 months, the scar that you produce will cause some maxillary growth retardation. What are the post-op medications given to the babies? Just painkillers, that's all. We do induction antibiotics, 1 dose of antibiotic at the time of induction, and then just painkillers, nothing else. Lateral incision, if not closed primarily, what is the material used to cover or keep it raw? Varun, your question. Lateral incision in a cleft palate, are you closing it primarily? If so, what is the material you used to cover it? Or Pashupati, that's your technique, right? Who wants to take it? Pashupati or Varun?
Yeah.
Come on, Pashupati. Yeah.
We if it's a very wide palate and the mucosal defect is almost closing the defect, and you have a large raw palatal shelf that is exposed, then in such cases we would tend to go in and use the buccal adipose tissue, the fat, and it is a pedicle graft. When you pull it along, you can find it just behind the shelf, the tubercle there, where you can just go underneath, use a sharp dissection and go into the buccal fat pad, and then pull it along. It's just a pedicle tissue that comes along. You need to do a careful dissection and then just suture it by using a couple of sutures onto both the available gingival tissue and the dissected palatal tissue, and it wonderfully heals, and within 4 or 5 days it completely epithelializes.
Jim, we have a few more questions. Do we have time, or should we have to call it a day?
Yes, sir. You can.
Okay, I will go at a quick speed now. Pardon me if I'm a bit rude. Lack of time. Naveen is asking a very, very important question. Thank you for the wonderful discussion. Could you please mention any specific anesthetic issues that a young surgeon anesthetics needs to be aware of? Naveen, whether you're a young surgeon, old surgeon, it doesn't matter. The one important thing that you need to be aware of is airway. In a child, the airway, you might slip out of your hands very, very quickly. You may not be able to intubate. You may extubate a little early and the patient may go into spasm. Airway. And that is, if your anesthetic is not good, it will become your headache. We can discuss this another time, Naveen, but it's a very important point you have raised. How to manage lip lengthening, which occurs as a result of bilateral maxillary lip repair. I am not sure what exactly we are talking about length wear. I know that in triangular flap techniques, you can end up with a longer length than is required. but I did not realize it was an exclusive preserve of the bilateral cleft lip repair. I will, for lack of time, not go into that discussion. Do you consider fracturing the hamulus in palate repair? People from Trichur do. They have their justification. I don't do it. Again, a controversial issue. You can look in the literature. What is the best ways to utilize the C flap in Millard's technique? You can use it to lengthen the hemicolumella. You can use it to the nasal sill. Where we do not do the conventional perielar base incision, we always use the C flap for lengthening the hemicolumella. So it's Millard 1 and 2 as has been described. Rick Mukherjee, sir, do we concentrate more on aesthetics than function like speech? I don't think you can do that. In cleft palate, there is no aesthetics at all. It's speech, speech, and speech alone. Whereas when it comes to the lip, both aesthetics and function are equally important. And probably they follow each other. If you have poor aesthetic, your function is not going to be good and vice versa. Okay, right. So where are we? Next question. Okay, this is a long question. Would simpler understanding of Tennyson be that the back cut at the base of the columella in Millard's is in fact in middle of the incision line in case of the Tennyson, with the additional principle of equilateral triangle added? Abhilasha, do you agree with that?
Not really.
What he's saying is that instead of doing a rotation at the base of the columella, you're doing a back cut along the length. That's a basic difference. That's what he's saying. Agree? Disagree?
Can say, sir.
Huh?
I agree with that.
Agree. I think that's the point he's trying to make. Okay. Sometimes water sips are not enough to remove slough from the repaired palate. Pashu, this is for you. Please suggest, can the slough cause a wound dehiscence? So we use that sip of water, but is that always enough, he asks?
A dirty palate never breaks down. Remember, this is a open wound. It doesn't get infected easily. So even if you have food getting stuck onto sutures for a longer time, it should not break down unless you've done a real good muscle dissection and done a 3-layer closure. It should not break down. And again, the stress is on a tension-free closure. So a dirty palate should not break down.
Right. Very good answer. Pashu, I fully agree with you. A lot of time the slough comes because the blood supply has been compromised, you know, and then so oftentimes we believe that our palate broke down because it got infected. Most of the times, I can't prove this. I believe that it is the blood supply that got compromised. There was sloughing and the wound got secondarily infected. I agree with you. It sometimes looks dirty when there is some idli or something stuck there, but I think it's very uncommon for it to cause, but this is just an opinion. We can't prove it. The next question I won't be able to answer because I don't know what exactly the person is referring to. What are the primary steps to be taken at relapse? Relapse of what? We don't know. Lack of time, will move on. For bilateral cleft lip, do we operate lip and pre-alveolus together? Pre-alveolus, yeah. If you're talking about the nasal layer, yes is the answer. In case of bilateral cleft lip and palate cases having protruded premaxilla, how do we create labial sulcus when repairing the lip? I think I will answer this question. We use the prolabial mucosa. So when we do the reconstruction, the mucosa from the prolabium is not used for reconstruction of the lip. The prolabial mucosa is turned upside to create a sulcus. It always results in a nice deep sulcus. Let's go to the chat box and see if there's any more questions. When will the recording be available? Miss some part. Jim.
Yes, sir.
You will inform them. Yeah. Sherish is asking this when it will be available because he or she missed the early part.
From Wednesday.
Wednesday. Oh, from Wednesday. Okay. Another question here from Pallavi. Is it easy to take impression to prepare molds in NAM? It's not very easy. I think we discussed there is a risk of that if the material flows down into the throat, etc., it can be a problem. The other problem is the trace. Remember, this is a small baby. Where do you get the trace to take impression from? So you know, our orthodontists are ingenious. From the pre-existing cast, they make trace. Yeah, it's a difficult thing. Pallavi, I hope you are a surgeon because it's always interesting to do surgery. These kind of details you can leave it to your orthodontist. They're quite capable. Sorry. Manju also wants Jim to send him the recording. You have to send it to Manju. Okay. Right. Some of these questions, I think you have transferred, Jim, from here to there, right?
Yes, sir. Yes, sir. It's
Yeah. So I think we have. I must say it's not only surprising that we have 240 people after 2 hours. That we had about 30 questions. Jim, I must thank you. Bow your head, because I've never had a maxillofacial cleft session where I had to get animated and freak out. That was amazing. Thanks, Jim. We are done.
Thank you, sir.
Yes, one question from Dhanalakshmi. Yes, Dhanalakshmi, I wanted to talk about this. This question is, will digital scanners be helpful for taking impressions? Of course. I am planning to get hold of one, but the quote for that is 16 lakhs. I will find the money, but I think it's very important that it will get rid of all these issues. But also the expert who is helping me buy this scanner says that if the teeth are not there, it may be difficult to do it. But today the quote for the digital scanner to take an impression is 16 lakh rupees. So yes, when we have the money, we will use them. I think it's an important point. Really challenging questions, really interested questions. Audience here for 2 hours. It's amazing. Jim, you are a star. Thank you.
No doubt.
No doubt, yeah.
Thank you, sir. That was a fantastic session. Thank you, Krishnamurthy sir's vast experience. You have brought in your vast experience in having this wonderful discussion, and it was indeed a very good learning experience for every one of us.
Credit to all the panelists. They
Yes.
were free flowing. Yeah.
Yes, sir. And thank you for accepting our invitation and spending your valuable time with us and all the participants. And I'm sure all the participants are enlightened from your experience. And thanks to all the young and energetic panelists, Dr. Abhilasha, Dr. Varun, Dr. Pasupati, and Dr. Sneha. It was a wonderful discussion and spot on. And thank all the participants, from senior surgeons like Professor Pal Samru, who is joined from Australia, Dr. Ashok Dabir, Dr. Nyanam, Dr. Manikandan, Dr. Prasad, Dr. Raviraj, to name a few. I may have missed out some names, just browsing the participants list. I could see these senior people joining us. To the young trainees, and I would like to thank all the heads of the department from all over India. Thank the National Association, AMSI, for their wonderful support, the Executive Committee of the State Association, and the members of the state branch. And to the question which I've already answered, the recording will be available in our YouTube channel from Wednesday. I'll try to make it available before that. And all the recordings of the previous webinars are also available. And the YouTube channel link can be found in the feedback link that I've already posted in the chat box. And there's one more announcement, that the certificates for the previous session, the OOO symposium, is still not being sent. It will be done by tomorrow or day after. And the President, Dr. Reena John, joins in sharing her best wishes to the moderator, Krishnamurthy sir, and the other panelists. She's unfortunately held up in some other program, so she's not able to join us. And all thanks to Stryker for their wonderful support week after week, for all the technical support and everything. Yeah, thank you. And I will repost the feedback again for the benefit of the participants.
What about the beers, Jim?
Sir, when we meet, sir,